Welcome everyone to the webinar of this week, and it is about cardiac physiology and shock, high yield for the USMLE exams, both step 1, 2, and 3. And before we start, I'd like to introduce myself. So my name is Dr. Ammar, and I am an IMG doctor. I have been tutoring for 6 years now. I passed step 1, scored 270 on my step 2 CK exam. And I've been guiding and helping a lot of students to pass their exams. And today, I'd like to help all of you with understanding one of the most challenging topics, I think, in all of the USMLE steps, which are the topic of shock. And it is covered on all 3 different steps. And we're going to go through the most important cardiac physiology related to shocks, so we can better understand shock. And then we're going to go through the different types of shock. What does shock mean? The different causes of the different types of shock and the different managements as well for each one. And then we're going to summarize all of that. And then we're going to be doing 2 or 3 questions that are long form, similar to how the questions on the exam are going to be, so we can apply all of the information that we've learned. So without further ado, I'm going to start with talking about cardiac physiology and shock. And to properly understand shock, we have to understand what is shock. So shock is a state where the organs are not getting enough perfusion. They're not getting enough blood flow. And this is almost in all cases on the USMLE is going to be associated with low blood pressure. So when we have low blood pressure, it means that we're not perfusing the organs. And then we're going to have a lot of different signs and a lot of different symptoms related to organ dysfunction. And if this goes on for a prolonged period of time, then this will lead to multi-organ failure and death, a common cause of death in the hospital states of shock. Now, to properly understand shock, we have to understand what are the determinants, since we said it involves low perfusion because of low blood pressure. We have to understand what are the determinants of blood pressure, what controls blood pressure. And mainly we have 2 variables that determine and control blood pressure. And these 2 variables are 1, the cardiac output, and 2, the systemic vascular resistance. Both of them control blood pressure. And cardiac output, what does cardiac output mean? Cardiac output means how much blood is the heart pumping in 1 minute. Okay, so it's a surrogate, or it's a measure of how well the heart is functioning. And the second variable is the systemic vascular resistance. So systemic vascular resistance, or also can be called afterload. It is basically a measure of the resistance that the heart has to be pumping against. Because the heart, you can view the heart as a pump, and it's trying to pump this blood around the body, in the vascular system and all of the blood vessels. And in order to do so, the heart has to overcome all of this resistance. And this resistance mainly comes from the arteries and the small arterioles all over the body. And the systemic vascular resistance, in order for us to measure it, there's a really long formula that I don't really want you to memorize or to know all of the different variables. I just want you to know the single most important variable that determines the systemic vascular resistance, also called interchangeably total peripheral resistance. So both of these words can be used interchangeably. Now, the systemic vascular resistance is mainly associated or inversely correlated with the diameter of the blood vessel. So it's a long formula, but we can break it down into the most important variable, which is the diameter, because the diameter is going to be to the power of 4. So any slight change in the diameter, like maybe if the diameter doubles, then the systemic vascular resistance is going to fall 2 times 2 times 2 times 2, 16 times. Also, if the diameter narrows by half, then the systemic vascular resistance should shoot up or increase 16-fold or 16 times. And the relationship between them is inverse, and that's what mainly determines the systemic vascular resistance. Okay, now coming back to the equation for the blood pressure, since we said that shock involves low blood pressure, and that is your biggest clue in all of the USMLE questions, that this is a question about shock, if you see the blood pressure being low. And now if the blood pressure is low, it could be either one, cardiac output, which is going to be decreased in almost all different types of shock, except for one type, which is the distributive shock, which is going to be involving the systemic vascular resistance dropping. So it's either this or this. Now we said systemic vascular resistance mainly depends on the diameter. Now what about the cardiac output? Now, since we said that the cardiac output is how much blood the heart is pumping in 1 minute, then it is a product of the stroke volume, which is how much blood the heart is pumping in one single heartbeat, times the heart rate, which is how many heartbeats per minute. And the product of those is going to be the cardiac output. Okay. Now, the heart rate is pretty straightforward. It's just how many beats per minute. The stroke volume is dependent on two different variables. Okay, so what determines the stroke volume, or what determines how much blood are we pumping in one heartbeat? And it depends on two things, which are, number one, the preload, which is a very important concept that we have to understand, and number two is the contractility. And then once we start going through the shocks, and I'm going to reflect back on this diagram to kind of put everything into place and integrate everything. So the preload is basically how much blood is coming back to the heart, or how much blood is the heart does the heart have available to pump forward. And the contractility is just a measure of how strong the heart can contract. The stronger the contraction is, the higher the contractility is, and thus the higher the stroke volume, or how much blood we're going to be able to pump. Same with the preload. And the preload depends on two things. Okay, how much blood is coming back to the heart. Depends, number one, I think this is self-explanatory and the logic can be followed easily, on the volume of blood available in the body. How much blood do we actually have? Are we dehydrated? Do we have enough blood volume? And it follows that if we have adequate or enough volume, then we should have adequate or enough preload. And the second variable is the venous tone, okay? The venous tone, or in other words, we can say the venous capacitance. Because we think that, or we look at the veins as what we call capacitance vessels, because the veins are pretty stretchy. They can stretch and they can hold large volumes of blood in the veins. Actually, most of the blood in the circulation at any given point is going to be found in the veins. And even if you have a fixed volume of blood in the body, the preload can change, or how much blood coming back to the heart can change depending on the venous tone. Is the venous tone increased? And tone just basically refers to the level of contraction in the veins. The higher the tone is, the more contraction in the vein there is, and then the narrower the vein is, and more blood is going to be shunted back to the heart, because the veins, they drain all of the tissues and all of the blood from the tissues, and they bring it back to the heart. So you can have the same amount of volume in someone, but their venous tone is increased, and that means that all of the veins are constricted, and thus they're going to have higher preload. Or it could be that their venous tone is decreased, so their veins are bigger, their veins are dilated, their veins are holding much more blood in them, and now less blood is coming back to the heart, and there's less preload. So it looks like a tree, but if you think about it in this way, this is going to help you navigate the different types of shock and what changes in each different type of shock. And we're going to come back to this to see what is going to happen in each different type of shock. So let's start with the first type of shock, hypovolemic shock. And before we start discussing all of the different changes or the causes of hypovolemic shock, we're going to talk about the different variables that you're going to be asked about on the exam related to different types of shock. And what are those variables? So, number one, we already talked about cardiac output. You're going to be asked about that. Number two, we already also talked about systemic vascular resistance, or the level of constriction or dilation in the arteries. You're also going to be asked about that. Now, there's two more pressure measurements that you also have to understand properly, which are the central venous pressure and the pulmonary capillary wedge pressure. So let's talk about those. Number three, or the central venous pressure. So the central venous pressure is the pressure that we measure here in the superior vena cava, okay, or the inferior vena cava in the venous system. That's why it's called the central venous pressure. And the central venous pressure, for all practical means, just means or is a measure of how much blood is coming back to the right heart through the veins. So the central venous pressure can be looked at as the preload here. So the preload coming back to the heart, that's also the central venous pressure. Also, we can look at the central venous pressure, since it is the pressure that is found in the superior and inferior vena cavas. We can look at that as the same pressure that is found in the right atrium. The right atrial pressure is also another surrogate for that. So right atrial pressure is the same as the central venous pressure, and in effect is just a measure of how much blood is found in the venous system that is draining back to the heart. More blood draining back to the heart, or the veins are congested with blood, means higher CVP. And we're going to see how clinically that would present when you have a high CVP. Now, the pulmonary capillary wedge pressure is another variable that we measure clinically through a catheter that we call the Swan's-Ganz catheter. And what basically happens is that we're going to insert a catheter all through the heart and then through the pulmonary artery, and then we're going to lodge it through a balloon here in the pulmonary artery, and then the tip is going to measure the pressure after the balloon, so in the capillaries of the lung. That's why it's called the pulmonary capillary wedge pressure. And it measures, it's called a wedge because we're going to wedge the balloon inside of the pulmonary trunk, inside of the pulmonary artery, and then we're going to inflate this balloon and measure the pressure after it. So we're only measuring the pressure in the pulmonary capillaries of the lung. And this pulmonary capillary wedge pressure is a surrogate for how much blood is going or coursing through the lungs, and how much blood also in effect is coming back to the left atrium or to the left heart, because the normal hemodynamics of the heart involve deoxygenated blood or venous blood coming back to the right heart, as we can see here, and then being pumped by the pulmonary artery into the lungs, and then after being oxygenated by the lungs, they're going to come back to the left side of the heart, mainly to the left atrium. So the pulmonary capillary wedge pressure can also be thought of as the left atrial pressure, because the pressure inside of the pulmonary capillaries is going to be transmitted directly to the left atrium, and they're going to be these two pressures, the pulmonary capillary wedge pressure and the left atrial pressure, they're going to be interchangeable. Also, in other words, the pulmonary capillary wedge pressure is going to measure for us the left ventricle preload, or the left heart preload, how much blood is coming back to the left ventricle from the lungs. The same as the fact that the CVP, or the central venous pressure, is going to measure for us the right ventricle preload, or how much blood is coming back to the right heart. Now, there is a description. Usually they move together, because the blood coming back to the right heart should be pumped throughout the lung, come back to the left heart, unless there is something that causes both of them to dissociate and to move opposite to each other, which is going to be, in one unique case of shock, obstructive shocks that we're going to talk about later, and all of the unique etiologies and causes of obstructive shock. But generally speaking, the central venous pressure and the pulmonary capillary wedge pressure, which are surrogates for the right ventricular preload and the left ventricular preload, should move together. Okay, now let's talk about hypovolemic shock. After we've talked about all of these variables, there is one small variable that I'm going to talk about towards the end of the lecture, since I don't think it's that high yield as these ones. And we're going to talk about hypovolemic shock first. And we're going to be talking about what, for every type of shock, we're going to be talking about what is the main problem, what is the main driver of the shock here. And I also want you to think in that way when you're doing shock questions or when you're studying shocks, because all types of shock, there is one defect that is causing all of the other consequences. So there's one problem, and then there's everything that follows this problem. And we're gonna see that for all the different types of shock. So let's first start with hypovolemic shock. So from the name, hypovolemic shock is a problem when you have low volume. So when you've lost blood. So one of the most important causes or etiologies of it is going to be bleeding. So when you are bleeding or when you're losing blood, this is the most common type of presentation. Sometimes you can be losing fluids without bleeding, but this is much rarer to happen in real life, like maybe very severe diarrhea, prolonged, or like vomiting, or if like a lot of sweating where you're going to be losing a lot of fluids, not through bleeding. But mainly on the exams is going to be a bleeding patient. And this bleeding can either be external bleeding or internal bleeding. External bleeding or internal bleeding. So you're losing blood from the blood vessels. The blood vessels, there is a defect somewhere, and you're losing blood through that defect, which can be external, so to the outside, and this should be a very obvious source, and sometimes internal bleeding, which is not as obvious. And so that's why for evaluation of internal bleeding, sometimes you can do maybe CTs or ultrasound to look for the internal bleeding, like CT of the abdomen, CT of the pelvis, ultrasound to localize where the bleeding is happening. Now let's go back to this drawing and see what is going to happen. So we said in hypovolemic shock, we're going to have low blood volume. So coming back to our drawing of all of the changes that are going to happen in, or that the variables that control blood pressure, this is the volume of blood, okay? And if the volume of blood is decreased because there is bleeding and you're losing volume, then that means that the preload is also going to decrease, right? This means that less blood is going to be coming back to the heart. So here, since you have less blood in your body, the blood that is coming back from the inferior and the superior vena cava to the heart is too little compared to the normal healthy person. So this is going to decrease the preload. And we said that the way that we measure the preload, or the pressure that correlates to the preload, is the CVP, or the central venous pressure. And the central venous pressure is determined by how much blood do we have inside of the venous system coming back to the heart. So the first thing that is going to change in hypovolemic is the central venous pressure dropping. And I look at this as the main defect, or the primary problem that is going to happen in hypovolemic shock. Is you're going to have a decrease in the central venous pressure, or the preload, or how much blood is coming back to the heart. And then everything else is going to follow. So let's see what is going to happen. Now, since you have less blood coming back to the heart, then the right atrium is not going to fill with enough blood. This blood is going to move into the right ventricle. Also, not a lot of blood is going to fill into the right ventricle. This is going to be pumped through the pulmonary artery, through the lungs, and then come back to the left atrium. But here, this is where the PCW also is going to be affected. The PCWP, which is, as we said, is going to be the pressure that we measure in the pulmonary capillaries, or a surrogate for how much blood is coming back to the left heart, since now we have less blood in the right heart, and then we're going to be definitely having less blood coming back to the left side of the heart. So the PCWP should also fall, okay? Now, and less blood is coming back to the left atrium, less blood is coming back to the left ventricle, and now the left ventricle has to be pumping this blood through the aorta into the rest of the vascular system and into the rest of the body. But since there is not enough blood coming back to the left ventricle, then how much blood the left ventricle is pumping is going to fall low. And this is going to be reflected here as a decrease. And since there's a decrease in the preload, there's also going to be a decrease in the stroke volume, or how much the left ventricle is pumping. And thus, this is going to be reflected as a decrease in the cardiac output and a decrease in the blood pressure. And you're going to have all of the manifestations of shock. Okay? Now, this is going to be the third thing we said. So this is going to be the second thing. And then the third thing is going to be less cardiac output. Okay? Now, there is a fourth mechanism or a fourth change that is going to happen, but this change is going to be mainly a response. Okay? Now, when the blood pressure falls in the body, which is going to happen in hypovolemic shock, one of the reactions is going to be for the body to upregulate the sympathetic nervous system to counteract this fall in the blood pressure. And how that usually happens is that we're going to have receptors that are found in the carotid artery and maybe in the aorta, so maybe somewhere here in the carotid artery or in the aorta. And these receptors are called baroreceptors. So they're called baroreceptors because they sense pressure. Okay, so these receptors are very sensitive to blood pressure, and when they sense that the blood pressure has fallen, which is going to be the case in hypovolemic shock, they're going to respond by sending signals to the brain, telling the brain that the blood pressure is low, and the brain is going to respond by activating the sympathetic nervous system as a trial to raise the blood pressure or prevent the blood pressure from falling even more. And the sympathetic nervous system is going to do that by, number one, increasing the systemic vascular resistance. Okay? And how is that going to be mediated? That is going to be mediated by the alpha-1 receptors that are found on the smooth muscle cells of the arteries. We're going to constrict the arteries, and this is going to raise the systemic vascular resistance, because if you increase the systemic vascular resistance, you can increase the blood pressure a little bit, since we said the blood pressure depends mainly on two variables, cardiac output and systemic vascular resistance. And cardiac output is low in this case, so we can't change the other variable. Also, the sympathetic nervous system is going to try to stimulate the heart through the beta-1 receptors and increasing the heart rate, and also through the same type of receptors, beta-1 receptors, increase the contractility of the heart in an attempt to try to increase the cardiac output a little bit and prevent this fall in the cardiac output. And initially, if the blood loss is not severe, this might be enough to compensate and not to allow the blood pressure to fall. But if the loss of blood volume is very severe, then these response mechanisms or compensatory mechanisms are not going to be able to raise the blood pressure enough. Now, and this is going to cause the fourth and last effect that we're going to see in hypovolemic shock, which is an increase in the systemic vascular resistance. Okay? Now, what is the management of hypovolemic shock? And this tachycardia is known as reflex tachycardia. It is known as reflex tachycardia, yes. Now, what is the management? I think you guys can come up with that really easily. The problem is you lost fluids. You have to fix that. How do you fix that? You give fluids, right? So you give fluids or you give blood products, but you have to supplement the body with fluid so that you can fix the low blood pressure or blood products. Okay. Now, I just wanted to talk about how do we relate some of these variables clinically, and then you're going to be able to see that in the questions and also in the other types of shock, which are number one, the central venous pressure. So the way that we measure the central venous pressure clinically is going to be through the jugular venous distension. Okay, so central venous pressure is when the superior and the inferior vena cava are congested. You can feel that and you can see that clinically. So if there is so much pressure, we will not going to see it in this case. But if there is so much blood found in the venous system that is congesting the venous system, this can be reflected as a JVD. But we're not going to see it in this case because the central venous pressure is low. And the pulmonary capillary wedge pressure, I'm going to also come back to this again when we talk about causes of high pulmonary capillary wedge pressure. This is going to manifest as lung crackles or wales in the lung, which are indicative of fluid in the lung. But this will only happen if the pulmonary capillary wedge pressure is low. For someone who's asking about this, on the top right-hand corner of the screen, it is, if I remove it, you guys are not going to be able to see me, but I'm going to make sure that it stays out of everything that I'm annotating. Okay, so the next type of shock we're going to discuss is a cardiogenic shock. And from the name, I think you guys can kind of figure out what is the problem going to be in cardiogenic shock. It's a problem with the heart, okay? Where the heart is not pumping effectively, or in other words, there is a failure of the pump where the heart is not pumping. And there are multiple causes for this, but probably the most important cause is going to be a massive MI, number one. And number two, you might have severe or advanced heart failure. So in both of these cases, you're going to have a process that is affecting the heart, and it's affecting the heart's ability to pump blood forward. So our main problem here is going to be the left ventricle, and the left ventricle not being able to contract and not being able to push the blood and eject the blood forward. And this is going to be reflected as a fall in the cardiac output. So a fall in the cardiac output is going to be the main or the primary disturbance that we're going to be seeing in cardiogenic shock. So if you go back to this drawing, actually the main problem in cardiogenic shock is going to be the contractility of the heart, where the heart is not contracting, especially the left ventricle. Mostly we're talking about the left ventricle because it is responsible for pushing the blood through the rest of the body. So the contractility is going to be going down, which means that the stroke volume is going to be going down, which means that the cardiac output is going to be going down, and thus the blood pressure as well is going down. Now, coming back to the drawing, now we have to kind of follow now what is going to happen as a result of this fall in the cardiac output and the problem in the contractility of the heart. Now, if the heart is failing to pump the blood forward or to eject the blood through the aorta, then less blood is ejected throughout the aorta, and this means that we have a low blood pressure and the signs of shock. And it also means that now we're not going to be able to pump enough the blood that is coming back to the heart or coming back to the left side of the heart from the lungs to the left atrium. Okay, so we have all of this blood being pumped forward by the right ventricle into the lungs and then coming back to the left side of the heart into the left atrium and then into the left ventricle. Now the left ventricle is not able to pump effectively. So all of this fluid is going to accumulate in the left ventricle and then it is going to backflow. Because one thing really important about the blood is that the blood always has to be moving. The blood cannot stay still because it's going to clot if it stays still. and the blood is going to always be moving. And if it's not moving forward, like in this case, since the left ventricle is not being an effective pump, it's going to start moving backwards. And it's going to accumulate and congest the left atrium. And from the left atrium, it is going to go back through the pulmonary veins into the lung, congesting all of the pulmonary capillaries in the lung, which is going to be reflected as an increase in the pulmonary capillary wedge pressure, which you can see clinically as pulmonary edema. Because all of this blood congesting all of the blood vessels or all the small capillaries in the lungs is going to start leaving these blood vessels and accumulating in the lung tissues or in the lung parenchyma, causing pulmonary edema, which on physical exam you're going to hear as crackles or rails. Characteristically, that's how they describe them on the USMLE exam. Crackles or rails on the lung. This means an increase in the pulmonary capillary wedge pressure. Okay. Now, the blood backflowing does not stop here. From the lung, all of this blood congesting the capillaries of the lung is going to be actually also coming back through the backflowing through the pulmonary artery into the right ventricle, congesting the right ventricle. And now the right ventricle has so much blood that it cannot also effectively pump forward through the lung because the lung is congested as well. And this is going to cause the fluid to come back into the right atrium, congest the right atrium, and then transmit it backwards into the venous system, into the inferior and superior vena cava, and congesting these veins. And then these veins are going to be dilated and filled with blood, which is going to be causing the increase in the central venous pressure. Since now all of these central veins are congested with blood and there's so much pressure here, which we're going to be seeing clinically as a jugular venous distension, because the superior vena cava is connected directly to the internal jugular vein that is found in the neck, and any congestion or increased blood found in the superior vena cava is going to be transmitted upwards into the jugular veins, distending the jugular veins. So this is the pulmonary capillary wedge pressure is going to be secondary. The increase in the central venous pressure, this is going to be the tertiary. And here we're also going to follow the same logic that we followed for the hypovolemic shock. Any case of decrease in cardiac output and a fall in the blood pressure is going to cause activation of the sympathetic nervous system, which is going to try to increase the blood pressure by activating the alpha-1 receptors found on the arteries, increasing the systemic vascular resistance, trying to increase the heart rate and contractility. And that's why the fourth and the last change that we're going to see in the setting of cardiogenic shock is going to be an increase in the systemic vascular resistance. Now, what is the management for cardiogenic shock? Well, the management has to also make sense to us. We have to understand what is the problem. We said that the problem is the heart. The heart is not contracting enough. So that's where the inotropic drugs come into place. So what are the inotropic drugs? They are drugs that increase the contractility of the heart. They help the heart contract better, contract with more strength or with more force, and maybe eject more blood into the circulation, which is going to relieve all of the congestion. So I also think about the heart as just like it's a pump, and it's responsible for sucking out all of the blood from the lungs and keeping it moving it into the arterial system. And if this pump fails, then the blood is going to backflow and the blood is going to congest the venous system. So to solve this problem in cardiogenic shock, you give inotropic medications, and these inotropic medications involve drugs like dobutamine, which stimulates beta-1 in the heart, and some other drugs that do not involve the beta-1, like milrinone. Okay, both of them increase contractility of the heart, which, as we said, it is the main defect from a physiological type of way. But for the exam purposes, they want you to think in terms of these four variables that we're discussing, and it would be the cardiac output, because a decrease in the contractility is going to immediately cause a decrease in the cardiac output. Now, okay, so one last thing before we move is, okay, well, yeah, I mentioned this, so the pulmonary edema and the JVD, because now we're going to see the contrast in one unique type of shock, which is the obstructive shock, okay? And the obstructive shock is unique because it involves obstruction to blood flow in the cardiorespiratory system or the cardiorespiratory connection, because the heart and the lung, they act as one unit. The right side of the heart is going to be pumping blood to the lungs. The lungs is going to be returning all of this blood to the left side of the heart. Left side of the heart is going to be distributing all of this blood around the body, and then you repeat the circle every time you have one heartbeat. So they work as one unit. Now, if there is any obstruction in this pathway, this is going to be causing an obstructive shock. And there's three different types and etiologies and causes of obstructive shock. And all of them, they share the very, very similar pathophysiology. And for the purposes of the USMLE, it's going to be the same, so you don't have to be thinking about the minor differences between each one of them. And these three are: number one, pulmonary embolism; number two, attention pneumo; and number three, a cardiac tamponade. And each one of them has their own unique characteristic set of symptoms that we also have to know what type of shock this is. So let's first talk about pulmonary embolism and discuss what is going to happen here and what are the changes in the variables that are going to happen in all of the different types of shock. So in pulmonary embolism, usually it has to be a really massive pulmonary embolism. And just to make things simple enough, what is a pulmonary embolism? A pulmonary embolism, it is a clot that travels. Usually it originates from the legs, okay, like a DVT, a deep venous thrombosis in the veins of the leg, and then travels through the venous system back to the heart, and then lodges into one of the branches of the pulmonary capillaries, like what we see here. So we have a big clot here obstructing, that's hence the name obstructive, obstructing blood flow from the right side of the heart through the lungs to the left side of the heart, through the rest of the lung, and then back to the left side of the heart. So what are the effects that are going to happen? So this is obviously the primary defect that is going to happen here. But in the terms of the variables that we have, now let's follow the pathophysiology together. Now, since there is the right ventricle is having so much increased resistance to blood flow, it cannot pump blood effectively through the lungs because of this big blood clot obstructing the blood flow. So the right ventricle is not going to be able to pump enough blood forward. So what is going to happen is that this blood is going to accumulate in the right ventricle and then congest the right ventricle, and then it's going to backflow into the right atrium and then go back to the venous system and congest the venous system. So a central venous pressure is going to be increased in the setting of an obstructive shock, and this is the primary change that is going to happen in obstructive shock. Now let's also follow what is going to happen. Now, since we are not pumping enough blood through the pulmonary system, since we have a huge obstruction because of this big clot hindering the blood flow through all the lungs, what is going to happen to the pulmonary capillary wedge pressure, which is mainly determined, as we said, by how much blood is flowing through the lung circulation? It is going to be low. So the pulmonary capillary wedge pressure is actually going to fall, okay, which is going to help us differentiate between this and between the cardiogenic shock that we just talked about. Because in cardiogenic shock, the pulmonary capillary wedge pressure is going to be increased since the left ventricle cannot pump blood forward, so it cannot effectively suck out all of the blood from the lungs. But in the setting of an obstructive shock, since we cannot really be sending the blood through the lungs, then you're going to have very little amount of blood actually coming back to the left atrium, and that's also why you're going to have a decrease in the pulmonary capillary wedge pressure, which is going to be reflected clinically as dry lungs, or clear lungs. So the lungs are going to be clear, while in the cardiogenic shock, the lungs are going to be wet, or the lungs are going to be full of fluid. So dry or clear lungs. Okay, so let's follow the pathophysiology. Now, less blood is coming back to the left side of the heart, less blood that is found in the left ventricle, and now the left ventricle is not going to be pumping enough blood forward. So this is going to decrease the cardiac output because you're not having enough blood come back to the left ventricle, and the left ventricle does not have enough blood to pump forward. So if you don't have enough blood pumping forward, the stroke volume is going to fall down, and the cardiac output is also going to fall down. What about the systemic vascular resistance? The systemic vascular resistance is going to be following this same pathophysiology for all of the three different types of shocks that we discussed up till now. The hypovolemic, the cardiogenic, and the obstructive, all of them are going to share an increase in the systemic vascular resistance. And once we summarize everything, we're going to talk about what that means clinically as well. Okay? Now let's talk about the other ones, but I want you to know that all of them are going to be having the same change in variables with a congestion in the venous system because you have some limitation of blood flowing from the right side of the heart to the left side of the heart. And so let's talk, for example, about tension pneumothorax. So tension pneumothorax is when you have a puncture in the pleura of the lung, which is the lining around the lung, that allows air to escape into the lung. And then what is going to be happening is that this air is going to accumulate around the lung, in the pleura around the lung, and this is usually involving a one-way valve mechanism where blood can come into the pleura but cannot leave the pleura. So it's going to accumulate there, and then it's going to compress all of the structures that are found in the chest, including the lung. The lung is going to get smaller because it is compressed by all of the air surrounding it, and also we're going to be compressing the heart in the mediastinum, okay? And now compressing the heart and the structures of the mediastinum, this is mainly going to be compressing the vena cava. Now you might be wondering, why the vena cava? Why not the other structures? So why not the aorta, and why not the heart itself? And the reason for that is, out of all of these structures, the vena cava has the lowest pressure. Veins in general have very thin walls. Compare that to the aorta, for example, which have they have really muscular walls, thick walls, and they're used to higher pressures. So they do not, they're not compressed easily. Same as the heart. The heart has a lot of thick muscle, and they can withstand higher pressure, so they're not compressed easily, unlike the vena cava. So all of this air accumulating in one side of the chest is going to compress the structures in the chest, and the most important structure that is going to compress is going to be the vena cava. And when you compress the vena cava, this is going to impair blood from coming back to the heart, okay? And now you're going to have all of the fluid congesting the vena cava and not being able to fill the heart. So the heart is not going to be able to fill the right side of the heart. So you're going to have a decreased volumes in the right side of the heart, okay? Even though that the contractility or the ability of the right heart to contract is still preserved, it did not change much. But what changed is how much blood is coming back to the right side of the heart. And so the blood is going to be congesting these vessels, the vena cava and the superior vena cava and the inferior vena cava, because they're constricted and they cannot effectively empty into the heart. So you're going to have an increase in the central venous pressure. But the amount of blood actually coming back to the heart is very minimal. It's because this obstruction is limiting blood from coming back to the heart and congesting all of these veins. And now less blood in the right ventricle, it means less blood is going to be going throughout the lung, and less blood is going to be coming back to the left side of the heart. So there's a decrease in the pulmonary capillary wedge pressure, and now there is a decrease in the cardiac output because not enough blood is coming back to the left side of the heart, and an increase in the systemic vascular resistance as a compensatory mechanism. So exactly same set of changes as pulmonary embolism. And the last one is going to be a cardiac tamponade, which is a problem when you have so much fluid or blood surrounding the heart and compressing the heart structures, okay? Now let's apply the same kind of logic. all of this blood surrounding the heart is going to be compressing the heart. Which side of the heart would you say is going to be compressed more? Is it the thicker side that usually deals with much higher pressures, which is the left side, or the side that has less pressure and is not as thick as the left side, which is the right side? It is the right side. So the right side of the heart is going to be actually compressed and squeezed from all of the accumulation of the blood surrounding the heart, and this will cause what we call impaired diastolic filling. Okay, so the right side of the heart is not going to be able to relax and dilate and fill with blood, which is going to cause what we call impaired diastolic filling. So diastole is just relaxation of the heart, where the filling process with blood happens. And when you have impaired diastolic filling, it means that the heart cannot fill with blood in diastole and or in the phase where it relaxes. And this means that all of the blood that should be coming back to the heart is stuck in the veins in the superior inferior vena cavas, which is going to be increasing the central venous pressure and congesting these veins. And now, since the right side of the heart cannot fill with enough blood to be pumping throughout the lung, then the amount of blood coming back to the left side of the heart through the lungs is going to be decreased, and the pulmonary capillary wedge pressure is going to be decreased as well, which follows that we're going to have a low cardiac output and an increase in the systemic vascular resistance. Now, some extra clues that will help you, because this is a unique type of shock, some extra clues that will help you to pinpoint what type of obstructive shock this is. So in pulmonary embolism, usually you're going to have either a trigger, a characteristic trigger, like we have what we call the Virchow triad, or the Virchow triad is basically all of the factors that increase the risk of hypercoagulability. Things like, for example, surgery, pregnancy, immobility, like bed rest or bedridden, long flights, use of some estrogenic drugs like OCPs. All of these, or sometimes also it could be a congenital disease or congenital hypercoagulability. So these triggers we have to be looking for in the question, a trigger that this patient has an increased risk of forming clots. And then clinically, mostly you're going to see evidence of a DVT forming in the leg, and then it embolizes to the lung and causes this characteristic feature. Second of all, tension pneumothorax. Tension pneumothorax can either happen in the setting of trauma. Sometimes it can happen in the setting of chronic lung disease, like asthma or COPD. But what you characteristically are going to see, you're going to see unilateral absent breath sounds. So unilateral absent breath sounds from the side that is collapsed or from the side that has filled with air. In addition to, you can also see hyperresonance on percussion. So the percussion note of the lung is usually resonant because it's a hollow structure. Where you tap over it, it's going to be resonant. But when you have pneumothorax, you're going to have air, and it is pure air, not just air and lung tissue like normal. So the note is going to be hyperresonant, and also you might see, or they might tell you, that we have tracheal deviation, where the trachea is deviated away from the side of the defect. Tracheal deviation away. So if for example, the pneumothorax happened on the right side, air is going to be accumulating on the right side and pushing everything in the chest towards the left side, including the trachea. So the trachea is going to be deviated to the other side, away from where the pneumothorax originated. And for cardiac tamponade, can happen in the setting of pericardial effusion, can happen in trauma, can happen if you have like MI as a complication of MI. In order for you to recognize it on the exam, you have to look for Beck's triad. What is Beck's triad? It's three things. Number one, you're going to have the low blood pressure or the hypotension, as we said, because this is one type of shock, and all shocks have low blood pressure. and then you're going to have the jugular venous distension. Why? Because we said there's going to be impaired diastolic filling. The heart is not going to be able to fill with blood the right side, and then all of this blood that should be filling the right side is going to be backflowing and congesting the systemic veins like the superior vena cava and the jugular veins, causing a jugular venous distension. And the last part of the triad is going to be the muffled or decreased heart sounds, and this happens because of this is going to happen because you have all of this fluid or blood accumulating around the heart, which is going to insulate the sounds coming from the heart. So when you put the stethoscope, you're either going to hear a muffled heart sounds, or you're not going to be hearing heart sounds at all, or they're going to be super faint. So muffled heart sounds, this is Beck's triad. And the management is going to be also depending on the etiology. And that's why for obstructive shock, you have to carefully evaluate the situation and see what type of shock are we dealing with. And then for treatment, so for pulmonary embolism, it's going to be, if it's a massive pulmonary embolism, you can use alteplase or drugs that are fibrinolytic to kind of lyse the clot that are formed, or you can use anticoagulants like heparin to break off this clot and prevent more clots from forming. For tension pneumothorax, it's pretty easy. We're going to do what we call a needle thoracostomy. And the needle thoracostomy involves inserting a needle into the part of the lung that has all of this air and allow air to escape through this needle to the outside, which is going to relieve all of the pressure that has built up in the chest because of this air accumulating around the surrounding of the lung. And a cardiac tamponade involves a similar process, which is called pericardiocentesis. Where you're going to be inserting a needle into the space surrounding the heart, and this is going to be empty the heart. Yes, actually, in cardiac tamponade, the PCWP can paradoxically appear increased, okay? But this is a paradoxical result, and actually, clinically, in most cases, it is not going to be increase, is going to be decrease, the PCWP, because you're going to have huge limitation to blood flow throughout the lung. So clinically, PCWP is going to be decreased, but if you measure it through this Swann's gas catheter, it might appear as it is increased, but the USMLE is going to be treating that as a decreased PCWP, similar to all the different types of shock, not to obstructive shock, not to confuse you. Okay, and now we're going to be talking about the last type of shocks, which is distributive shock, which is a unique type of shock, different than all of the other ones, because here the problem is not going to be something related to the heart. It is going to be related to the arteries and the vessels. So distributive shock involves the main problem in distributive shock, okay, which is going to be unique from all of the other types of shock, is it is going to be the systemic vascular resistance falling, okay? Going back to the first page here, we said that the problem is with shock or low blood pressure is either going to be a low cardiac output or is going to be a low systemic vascular resistance. And in all of the other causes that we discussed, the hypovolemic, the cardiogenic, and the obstructive, all of them are going to involve low cardiac output and high systemic vascular resistance. Now, distributive shock is going to be different than all of those, where the main problem is going to be actually a fall in the systemic vascular resistance. And the two main causes that you need to be knowing for the step one are the septic shock or septic causes and anaphylactic shock. Now, there are some other causes, but they are minor and not high yield. So like neurogenic shock. Sometimes we have what we call a hormonal shock or a adrenal crisis, also not really high yield, and myxedema shock, where you have very low levels of the thyroid hormones. But these two, the septic and the anaphylactic shock, are the most commonly tested and the most high yield types of distributive shock, and both of them involve dilation of all of the arteries, okay? The arteries and the veins alike, all of the blood vessels. So in septic shock, is when you have this exaggerated immune response to an infection that you have in the body. And infections are associated with cytokines. Cytokines including interleukin-1, TNF, alpha, and many other cytokines. And these cytokines are going to be causing dilation, vasodilation of the blood vessels, which is going to cause the systemic vascular resistance to fall down. In anaphylactic shock, you're also going to have an allergic stimulus, something you're allergic to, like maybe peanuts, and then you're going to have widespread activation of the mast cells and eosinophils, and you're going to have huge release of substances like histamine, and histamine is going to be doing the same thing, causing extensive vasodilation in the body and a fall in the systemic vascular resistance. And so both of them are going to be sharing the same pathophysiology, which is a fall in the systemic vascular resistance. And this is unique because it's the only one with a fall in the systemic vascular resistance. So this is going to happen, is going to cause a very unique finding that we don't see anywhere else, which is going to be what we call relative hypovolemia, meaning that the volume in the intravascular volume, the volume of blood in the body did not change. But what changed is the diameter of the blood vessels. Now the vessels are much bigger, and now they're not filled with the fluid, because in order to have the blood vessels and the blood flow through them normal, they should be a certain size and they should be filled with blood. Now imagine you're going to have the same amount of blood that you have, which is around 5 liters, and now you just double the size of all of the blood vessels. So this blood is going to be found now in a bigger container, and that's why we call it relative hypovolemia, where you do have low intravascular volume, but it is relative to the new size of the blood vessels. Now, this is going to cause more blood to stay in the circulation, meaning more blood to stay in the veins, because the veins are going to get bigger, and now the veins are going to be holding more blood. Also, as part of the pathophysiology of distributive shock, you're going to have an increase in the capillary permeability. And an increase in the capillary permeability is going to cause more blood to be leaving the blood vessels into the tissue, okay, from the blood vessels into the tissue and accumulating in the tissue, and less blood coming back to the heart. So this is the main and the primary problem that we're going to have in distributive shock, and then everything else is going to follow. A fall in the systemic vascular resistance is going to be causing less blood to come back to the heart, and that is because now more blood is going to be staying in the blood vessels, since the blood vessels have just doubled in size, and also in the veins, since the veins also have doubled in size. Add to that the capillary permeability that has now increased, and now blood is also flowing outside of these blood vessels into the tissues. So the blood coming back to the heart, or what we call the central venous pressure, is going to fall, okay? And now also the blood coming back and then this blood is going to be sent through the lungs, coming back to the left side of the heart, which is the PCWP, is going to be falling down. And the last thing is the cardiac output, which is also unique, because initially, this is the only type of shock where this happens. Initially, the cardiac output can be increased as a compensatory mechanism for the fall in the blood pressure and the fall in the systemic vascular resistance. So coming back to the physiological map that we had in the start, so we said that we're going to have a fall in the systemic vascular resistance, causing a fall in the blood pressure, and this is going to cause an increase in activation in the systemic nervous system. So even though that the amount of preload coming back to the heart is going to be decreased in the setting of distributive shock, because now the venous tone has decreased and now the veins are holding more blood, and also the volume inside of the blood vessels, or as one of you saying in the chat, is decreased. The effective circulating volume has decreased because some of it is leaking into the blood, into the tissues. This is going to cause a decrease in the preload, but through the responses of the sympathetic nervous system, like increasing the contractility, increasing the heart rate, we might be able to actually cause the heart to be pumping more blood. So cardiac output is going to be high in early septic or distributive shock. Okay, so cardiac output is going to be high in early septic shock, but then towards the end or like late septic shock, the cardiac output is going to go down because of the depressant effect of all of the cytokines. The cytokines can also affect eventually the heart and also impair the contractility of the heart and cause the heart not to be pumping enough blood forward, and also because of exhaustion of the heart, because the heart's not going to be able to keep up with this high cardiac output for long, and a fall in the pulmonary capillary wedge pressure and the fall in the central venous pressure. Now, what is fixed about the distributive shock is going to be this one, a fall in the systemic vascular resistance, because all of these other ones, they might change, they might be variable. I've just given you what the USMLE likes to test and what they always assume is going to happen, a fall in the pulmonary capillary wedge pressure, which in some cases you might have some pulmonary edema and an increase in the pulmonary capillary wedge pressure just because of what we just talked about, the increased permeability of the blood vessels, where the blood is going to be accumulating in the third space and then filling up the tissues like the lung maybe. But the decrease in the systemic vascular resistance, this is always going to be the found in distributive shock, and it's going to be the cause of distributive shock all the time. Now, what is the management of distributive shock? The management is going to be dependent if it's septic or if it's anaphylactic. So if it's septic, you're going to be starting with antibiotics, okay? And then you are going to be supplementing with fluids, IV fluids, because these people are going to be intravascularly depleted. So the blood vessels are just doubled in diameter, and you need more fluid to fill these blood vessels, and also some of this blood is going to be leaving the third tissue. So actually, like relatively, the amount of fluids found in the blood vessels is going to be low. So you have to supplement with IV fluids, and then you add vasopressors. So vasopressors are drugs that are going to be constricting the blood vessels, constricting the arteries, helping increase the systemic vascular resistance and restore the normal blood pressure. Things like, for example, norepinephrine. For anaphylactic shock, it is going to be mainly IM epinephrine. And then you can supplement with some other medications like maybe corticosteroids and antihistamines. But epinephrine is going to be the main and the best drug for this. Corticosteroids and antihistaminergic agents. Okay, now let's put everything together and see what are we going to have. So, and also what kind of approach is the best approach for these type of questions on the exam. So hypovolemic, cardiogenic, and obstructive shock, we said that all of them are going to be having high systemic vascular resistance and low cardiac output. Okay? And distributive shock is going to be unique in the sense that it is the only one that is going to have low systemic vascular resistance, and cardiac output is going to be high initially, and then it's going to fall down towards or late in the course of the septic shock or the distributive shock. So first thing I think you should be looking at is the systemic vascular resistance, because it's going to tell you if this is distributive shock or another type of shock, okay? And now the central venous pressure and the pulmonary capillary wedge pressure are going to help us also differentiate between the different types of shock. So The central venous pressure and the pulmonary capillary wedge pressure in hypovolemic shock, since we said we have low volume in the body, both of them are going to be low. Also, in distributive shock, since we said that you're going to be relatively hypovolemic, or you're going to be intravascularly depleted, so amount of fluid inside of the blood vessels is actually low compared to the size of the blood vessels. So the CVP and the PCWP should be low as well in both cases. Now about cardiogenic and obstructive shock. In cardiogenic shock, you're going to have a complete failure of the heart of pumping blood forward. This is going to cause all of the blood to go back and congest the lungs and then congest the venous system. So both CVP and pulmonary capillary wedge pressure should be increased. Now, in obstructive causes, we said that there are some unique causes, but in general, all of them are going to have an increase in the central venous pressure and the pulmonary capillary wedge pressure, which will help us differentiate this between cardiogenic shock, is going to be low. And there's an asterisk because sometimes in the setting of tamponade, they might tell us that it is increased, but this is going to follow my logic of how do you look at this clinically. We clinically classify shocks as either cold or warm, and as dry or wet. Okay, what is the difference? So cold or warm, just from how you how everyone understands it, is from the temperature. So you're going to be sensing the patient's temperature, like you just touch their limbs and you're gonna either their limbs is going to be cold or warm. And this is related to systemic vascular resistance. So, and cardiac output. If the systemic vascular resistance is increased, meaning that all of the blood vessels in the peripheries are constricted to kind of help us increase the blood pressure, it means that there is very little blood flow through the extremities, since you have constricted the arteries so much. So now not enough blood is flowing through these. So all of these type of shocks, the hypovolemic, the cardiogenic, and the obstructive shocks, all of them, we call them cold shocks. Okay, while in distributive shock, which also could be a clue in the question, they're going to tell you the patient is cold and clammy. In distributive shock, what is going to happen is that the systemic vascular resistance is actually low, which means that the blood vessels are dilated, and this means that there's a lot of blood going through the extremities. When you touch the patient's extremity, the patient is warm, and distributive shock are going to be warm. So they're going to tell you the patient is, the skin is warm and flushed. That is a warm type of shock. So this is the first clinical description, cold versus warm. And the second thing is dry and wet. Now, dry and wet is mainly going to depend on the PCWP, or the pulmonary capillary wedge pressure, or how much congestion do you have in the lungs, and thus are you going to have lungs that are filled with blood and fluid that is seeping into the parenchyma or the tissue of the blood, causing a pulmonary edema, or no. So in cardiogenic shock, since that is high, we call this a wet shock. It's going in, and it's also a cold shock at the same time. So cardiogenic shocks are cold and wet, while, for example, hypovolemic shocks and obstructive shocks, both of them are going to be dry, since you're not going to have as much blood congesting all of the capillaries in the lung. And when you listen to the lungs is going to be dry, or the lungs is going to be clear. So these are the two clinical descriptions that we use: cold shock versus warm shock, and wet versus dry lungs. Okay? And the last thing, the last variable that I told you that I'm going to be discussing towards the end, is the SVO2, or the mixed venous oxygen content, which is basically just how much oxygen do we have here? Do we have in the right atrium, or the right ventricle, or the central veins? How much oxygen do we have in the mixed venous blood that is coming back to the heart? After just coming back from all of the different tissues, is going to accumulate in the vena cavas, or be drained by the vena cavas into the right atrium. And this is the oxygen, the mixed venous oxygen on the blood. And just to make things easy, generally, the SvO2 moves the same way as cardiac output. So if cardiac output goes down, the SvO2 should go down. And if the cardiac output goes up, SvO2 should go up, and that's why it goes up in distributive shock. And SvO2 is just a measure of how much extraction of oxygen happened in the rest of the body. So usually the normal amount is around like maybe 70 to around 75%. That's how much oxygen comes back to the heart, which means that the tissues have extracted around 25% of the oxygen that is found in the arteries. Now, in cases of maybe obstructive, cardiogenic, or hypovolemic shock, where you have low cardiac output and high systemic vascular resistance, not much blood is going through the tissues. So the tissues is going to decide to extract more blood, more oxygen from the blood coming there, which is going to cause a decrease in the systemic venous oxygen, or how much oxygen is coming back to the heart, to around like maybe 60% or something like that, because now the tissues are extracting more. And in distributive shock like sepsis, all of the blood vessels are dilated. The blood is passing very fast through these capillaries, and also there's endothelial dysfunction going on, and there's the blood leaving into the tissue, which is going to impair the extraction of oxygen. So actually, the amount of oxygen coming back to the heart should be like something like maybe 80%. So it would be a little bit higher because the tissues are not extracting as much oxygen as it should. And it generally moves the same as cardiac output, and I believe that this table will help you in answering a lot of questions on the exam for these type of variables, which is what I'm going to be doing right now. We're going to be going through some questions together, same as the exam, to try to apply all of the information that we've just learned about the different types of shocks. And this is from the Synapse question bank, the best question bank for the step 1. It's 1,300 questions, only the highest yield questions. So if you're not a fan of wasting your time and doing thousands and thousands of questions and trying to look for the questions that are high yield, I would highly recommend doing this question bank. So let's see the type of questions that we have here. Okay, so this is a 25-year-old man who is brought to the emergency department 20 minutes after sustaining a stab wound to the left chest during an altercation. So this looks like a trauma. And he is anxious, he is diaphoretic, he is short of breath as well. His temperature is normal, blood pressure is low, so this is shock. Pulse is 124. Usually pulse is elevated in shock because of the activation of the sympathetic nervous system. He is tachypnic as well. The systolic blood pressure decreases to 60 during deep inspiration. So this is what we also call pulsus paradoxus, where the blood pressure drops during inspiration. This is a characteristic feature of tamponade, but let's keep on reading. Physical exam shows a puncture wound and the left fourth intercostal space along the parasternal line. So yeah, this is exactly anterior to the heart. So probably this stab wound has punctured the heart in some way, or maybe the lining around the heart. The jugular veins are distended while the patient is sitting upright. What did we say that means? Like, in terms of the different physiological variables, this is going to mean that the JVD is increased, okay? Which means that the central venous pressure is high, okay? And we have low blood pressure, which means low cardiac output, or like also it could mean low systemic vascular resistance, but we have increased jugular venous pressure. Breath sounds are present and symmetric bilaterally. So the lungs are clear, which means that the PCWP is normal. Heart sounds are difficult to auscultate. So here we have muffled heart sounds and the hypotension, and also we have the jugular venous distension, all of the big triads, which is indicative of obstructive shock related to cardiac tamponade, accumulation of blood surrounding the heart. Which of the following is the most likely mechanism causing this patient's hypotension? What do you guys think? Okay, now they're asking you like how the step 1 exam would ask you, not what is this, but what's the underlying mechanism? And we said that obstructive shocks and tamponade in general, even though it does affect the contractility a little bit, it mainly affects the diastolic filling, or the ability of the heart to fill with blood. And I think it's B. A lot of you also think it's B, and let's admit it is B, and this is cardiac tamponade. Okay, let's see another one. Okay, this looks like all of these autos that are kind of scary sometimes. So let's see, a 23-year-old man is brought to the emergency department 30 minutes after being involved in a high-speed motor vehicle collision. So this is another case of trauma. He was the restrained driver. He complains of severe diffuse abdominal pain. He has abdominal pain on arrival. He's anxious. He's confused. Blood pressure is low. Temperature is normal. Pulse, he is tachycardic. Respiration, he is tachypneic. This is because of sympathetic nervous system activation. There is extensive ecchymoses across the lower chest and the abdomen, which means that this means that there's trauma to these areas. Ecchymoses are bleedings under the skin. The extremities are cool and pale, so this means that this is a cold shock. Capillary refill time is 4 seconds. So capillary refill time is one of the signs of shock, and in particular hypovolemic shock, because it indicates less perfusion. Jugular venous pulsations are not visible when the patient is supine. This means that central venous pressure is low, since you do not see the jugular venous pulsations. A bedside ultrasound of the abdomen demonstrates free fluid in the splenorenal recess. So this is the bleeding. So it means that this patient is bleeding into their abdomen. Which of the following sets of hemodynamic and laboratory changes is most likely present in this patient? And there's things that I have to explain. So we did explain the PCWP and the SVR. We did not explain what a cardiac index is, but for all practical purposes, you can consider cardiac index be the same as cardiac output. Cardiac index is just cardiac output divided by the surface area of the body. So it's a way to kind of standardize the cardiac output, but it's basically the same thing. Now, lactic acid in all types of shock, lactic acid should be increased. And it's actually one of the laboratory measures that we do to see if the patient is in shock. And the reason for that is, as we said, the cause of shock is impaired perfusion to the organs. The organs are not getting enough blood. And this means that they're going to switch from the aortic metabolism, the one that uses oxygen to extract energy through the TCA cycle and then the electron transport chain. And now, since they do not have enough blood flow, enough oxygen, they're going to switch to the anaerobic metabolism, which is going to produce lactic acid from glucose in order to produce some energy. And that's why in all cases of shock, lactic acid should be increased. And plasma ADH, antidiuretic hormone, is a hormone that has 2 stimuli. Just to explain a little bit about ADH before we do this question. So ADH is a hormone that has 2 main stimuli to be secreted. One is an increase on the osmolality. And number 2, it is going to be hypovolemia. Because what ADH does is that it is going to reabsorb more water from the kidney back into the blood. And this is going to dilute the blood, since it's free water that we're reabsorbing back. So that's why it's secreted in increased osmolality to kind of dilute the blood, and also in hypovolemia to get more water back into the body and help with the hypovolemia. So assuming that this patient probably is having a hypovolemic shock, hence the history of bleeding, so what would be the answer? First of all, I would think about the cardiac index. The cardiac index should be low, okay, which should limit me to option A, B, and C. Pulmonary capillary wedge pressure, since the lungs are clear, should also be low, which would limit me to option A and B. The systemic vascular resistance should be high. Now that's immediately option B, and we don't have to evaluate lactic acid and plasma ADH, but both of them should be high as well. So the answer should be B. I'll submit the answer, and that is a correct answer, and this is hypovolemic shock. So let's do the last one. Okay, well, actually, this is not related to our discussion. This is a question about pericarditis, one of the complications of Ammar. So we're going to be ending our session here, and I was really happy to go with you through the different types of shock. I tried to simplify things and not add in a lot of details that might confuse some of you. And I believe that this is a really good approach to shock that will get you at least 95% of all questions on shock. In 1 hour, I would say that's impressive. So make sure, guys, that I'm going to be sending you the link now on the chat for the webinar, because we do a webinar like this every week, and this is for you, so you can come every week and see the webinar that we do. And so I just sent you the WhatsApp link on here on the chat. If anything is not clear, you guys can reach out to me or reach out to any of our tutors here at the thematchguy, and you can ask about whatever you want. And I'm also going to be sending you the link for the question bank. It's called the Synapse question bank. You can try out 40 questions for free. It's an amazing question bank, and I encourage all of you to do it. And good luck in all of your exams, if they are close or they are far away. And hopefully I can see you soon. So take care, everyone, and bye-bye.